Um, Today is a very special because we are having a very dynamic, young, enthusiastic speaker. She is the rising star of IADVL arena. And if you had gone through the brief write-up, you might notice that she is presently occupying a number of posts in IADVL, and she is very active in IADVL activities as well as in dermatology, cosmetology, dermoscopy. I mean, and she is a versatile genius, I should say. And one peculiarity that she is not attached to any medical college as such. This should be an example for the young dermatologists in training, because you need not to have an attachment to medical college to have a very brilliant career in dermatology. And that is exemplified by Jayasree. So she is very well versed in dermoscopy. And in fact, the earliest dermatoscopist is she, and she right now pursues dermoscopy in an enthusiastic manner. So now you may come to know as the discussion goes on. Now I invite Dr. Jayasree for
that kind words of introduction. But I think the most important thing that you should have mentioned is that I am your MBBS student. You are the one who taught me from macule papule of dermatology. I belong to the first batch of undergraduate students in Amala from the year 2003. And it is the Amala Dermatology department who taught me first the basics of dermatology, which I still hold very dear. Crichton sir and other members of the department, as now also Abel sir, Anita ma'am, Reshmi ma'am, all. So that's where I began. So whatever I could manage, it has all started with you, and I'll always be grateful to you for that very prosperous beginning that you gave for me. And many of my undergraduate batchmates have become dermatologists, and I'm sure that your charisma did play a role in that. So thank you for this wonderful words of that you have spoken about me very kindly. So let us move on to the presentations. Shall I start my slideshow?
Okay.
So dermoscopy, the topic of the day, it's an overview, and I've tried to finish as much as possible in the 1 hour's time that we have got, and we'll do most of the basic practically relevant points about dermoscopy as well. So this is a wonderful paper that Crichton sir himself have authored, which shows how dermoscopy was evolved as a sub specialty of dermatology, I would say. And from this, in the 1920s, from where the subsurface visualization was made possible, the use of illuminating microscopes too, we have reached whole body mapping, where individual lesions of the entire body can be mapped, documented, analyzed with the use of AI technology to distinguish between the skin lesions. And similarly, so this is a similar dermoscopic application that we have in our place, which is a Leviacam with something called a Trichoscan, which can do trichoscopy of the scalp and individually measure each shaft length, thickness, whether it is terminal and vellus, and give a detailed report which can be stored for documentation purpose as well as given to the patient as like we do any other investigation. So dermoscopy is here to stay without much ado. And nowadays, dermoscopy has many subspecialties, like an of the scalp, which is trichoscopy. There are branches which deal only about the inflammatory conditions of the mucosal lesions of the nails. So it is not easy to uh, talk about dermoscopy in to cover all the aspects. And today in the presentation, I will be dealing mostly with dermoscopy as in the skin lesion alone. So what are the practical principles before we start doing dermoscopy or the importance of dermoscopy? We should realize that dermoscopy on its own doesn't stand. It is only a puzzle piece in the entire clinical examination, other history, and different management steps we take in a patient. So dermoscopy, but is a valuable piece in that entire puzzle because it can help us towards diagnosis, at least bringing out a set of differential diagnosis to prognosticate some kind of lesions, especially activity of certain diseases. For documentation purpose, we can always take the serial images using a dermoscope. And even if we can't come to a diagnosis per se, we'll be able to make a decision regarding whether to do a biopsy or not in a particular lesion, to select the site of the biopsy. And if at all we see something more sinister about a lesion, do not go for a biopsy. We need a complete excision. And if it is, and we're planning an excision, the extent of the excision, so rather than the gross view, it helps us in more specific findings of a particular lesion. So in this presentation, we will be covering dermoscopy from the point of view of a optical handheld dermoscope. So I'm sure that we all have seen a dermoscope at some point of time, and this is the one instrument that I use. It's a Dermlight DL4N, which is a handheld one. So it has a illuminating system here, which has the white light emitting diodes as the light source. It has an achromatic lens, of which the magnification is 10x, and there is a contact plate which is made of multi-coated silicon glass, which can be graduated. Some of them have measurements, and power supplies either with rechargeable lithium batteries or removable batteries. And newer dermoscopes have more additions, like the contact plate has some disposable sterile covers, which can be used in case of to prevent cross infections and to maintain sterility while examining. So, why do we need a dermoscope? To have that, we need a little bit of physics about the dynamics of light on the skin. So most of the light that falls on the skin surface is reflected. And this leads to something called a specular reflectance or glare. And what happens is we see only the visible surface of the lesion. All the light that undergoes diffraction and absorption inside the layers of the skin do not contribute to our visual assessment of the lesion. So what we need is basically to remove this surface reflectance and make the subsurface findings more visible. And we chanced upon this finding where this is actually a gross view of the lesion. And this is just a photograph taken with an ultrasound gel this was actually a clear gel-based sanitizer. This was something we did during the COVID period where more of the teledermatology and image sharing was going on. So we could just application of a thin layer of the gel, which reduces this glare itself, can make the findings of the lesion, of the deeper findings of the lesion more visible, which is clearly evident with this comparison image. So this is something we call the drop dermoscopy. What else can a dermoscope do? So this is the illumination source of a dermoscope, and we know there are two modes, non-polarized and polarized. So in non-polarized dermoscopy, we use a liquid interface along with a contact plate. So with a liquid interface, we try to adjust the refractive index in such a way that the reflecting light or the glare is reduced, and we see some amount of the subcorneal findings. So this you can see there are the this is the extent of the lesion, and here the glare and the dry scales are more visible. But here you can see something which is deeper than the clear, the direct examination, but not much deep. So a non-polarized view of dermoscopy helps in mainly the superficial view of the lesion. And when coming to polarized dermoscopy, what we use is a technique of cross-polarization. So that we use two polarizing glasses from the illumination source. There is one polarizer, the light which passes through that polarizer goes to the epidermis and dermis. Inside the dermis, it changes its angle and is reflected. So the first incident light which do not go inside and reflected is cut by the second polarizer, and what we see is only the light which has gone through the subsurface or the dermal layers. And this way we can see how from the non-polarized view, the polarized view gives us a better view of the deeper, in this case, the pigment deposit, and inside the follicle, which is the scale. So cross-polarization is a very important technique in polarized dermoscopy, and these are the two polarizers, and you can see how the light which goes through only the deeper layers are reaching the eye with the help of the second polarizer. This is another example where this is the non-polarized view. So you can see it is the surface findings. It is only the surface follicular plugging which is evident. And you can see this area only as a structureless whitish color. Whereas when we move to the polarized view, the deeper structures become more visible. You can assess the presence of the vasculature in the fashion within the follicles, and the follicular plugs are more evident. The fibrotic layers and even the white fibrotic structures are more visible. And changing the polarization from non-polarized to polarized makes some visible more, some findings more visible. It happens like a blinking finding, and that is what is called as a blink sign or toggle test. So if the question is to polarize or not, we need both. Non-polarized for the superficial structures, polarized for the deeper structures, and when using them complementary, we always it helps in a better global assessment of the lesion. And if you're avoiding the faceplate, most of the dermoscope now, the faceplate can be removed, and avoiding the faceplate can prevent the compression of the vasculature and better visualization of the vessels. There are more advances now. There are UV dermoscopy where ultraviolet mode is available. The latest model of, for example, Dermlight has a UV mode, and we had published about the findings which are more visible on the UV dermoscopy. Can see the extent of the lesion is better visible with UV. The scales are more visible. The findings like milia-like cyst and komodo-like openings in seborrheic keratosis also shows up better in the UV light. And more technologies are coming up. So this is a point and shoot camera, handheld camera, which was brought out by Casio, which has a polarized, non-polarized, and UV mode. And just like we take pictures with a shutter camera, we can take images of the skin lesions. So one of the initial problems with dermoscopy was that there were too many of these descriptive findings. For example, starry sky, when somebody says that it was a starry sky appearance, starry sky, at least for me, was one of the more, it was a more confusing description, because starry sky even changes every day. From one place to another, my starry sky won't be yours. So that was one common problem with dermoscopy and the descriptions in the earlier times, and that is how the standardization of dermoscopic terminology came up. And this is especially for the general dermatology, that is a non-neoplastic dermatosis. So for somebody who who's early in the dermoscopic use and is trying to learn, I would say that this is a very useful paper in which the important findings are standardized in their description. So let us briefly go through how each description comes up. So the beauty of this kind of standardization technique is that it's simple, it is straightforward, the subjective variations can be minimized, and it has its definite histological correlation. So all these comma shape or spermatozoa-like or glomerular, all those four, either the vessels are dotted, a linear or linear with branching or according so how you see the vessels within each lesion and how they are arranged within the lesion. That's also important. So it can be uniform or it can be only peripheral in the lesion. It could be non-specific or reticular. So let us see a few examples. So this is how the dotted vessels, you can very well appreciate the dots, the vessels in the dotted manner, and they are almost uniform in the lesion, whereas here the vessels are linear with some amount of branching, and most of it is central in location with some patches. So you can call it a patchy distribution of linear and linear branching vessels. Whereas here the linear branching vessels are more peripheral in location. The large caliber vessels are seen mostly in the periphery, and it comes out in a manner in the center. So this was how the crown vessels were demonstrated initially, or these are called the arborizing vessels. But you can use the terms linear branching of peripheral location and focus. It becomes a standardized terminology. Here you can see the vessels. They are patchy in distribution, mostly in the periphery, a few in the center. So if it is in this way, there are linear vessels and curved vessels can also be seen. So try to use these terminologies and it makes our description and learning easier. Coming to scales, similarly with the color of the scales, how it can incorporate only hyperkeratosis or presence or absence of serum and melanin. And scales also, the distribution can be used with the described with the use of these standard terminologies. So coming to the images, these are white scales mostly, but there are some amount of melanin and pigment. So the color of the scales you can describe as brown and white, which is covering the entire lesion. Whereas here, the white scales are mostly in the periphery. Only a few scales are in the center. The primary arrangement is of peripheral. And here you can see how there is a yellowish scale, which shows the presence of serum and other exudative um, discharge. Coming to the next element of follicular findings. So follicular plugs where the follicle is occluded by some deposit. So those deposits can be due to demoducts, it can be comedo-like openings. So any cause which occludes the plugs, whether it hyperkeratosis or combined with other elements, you can broadly call them as follicular plugs, whether it is follicular red dots or color difference in white or pigmentation. So using these terminologies gives us a better idea about the histopathological alteration that is going on in the lesion. So the schematically, you will see this follicular findings like this. And to show on dermoscopy, so these are white follicular plugs, which are smaller in nature. And there is some amount of pigmentation in the surrounding. It's a patchy pigmentation with some periacrine accentuation. Whereas here also the plugging is follicular, but you can see this is larger. It is more keratotic in its appearance, and along with the follicular plug, you see these zones of changes. There is white color, which shows some amount of fibrosis. Then there is perifollicular halo. And when it is alone, pigmentation alone, this is perifollicular pigmentation, and this is perifollicular depigmentation. Both shows changes seen commonly in vitiligo according to the stability of the lesion. Acrine finding. So other than the follicular opening, we do see large number of acrine opening on the skin. So broken hairs which may come out within the acrine openings as well, along with the acrine openings, and pigmentation or osteobliteration. So this is a zoomed view where you can see there is pigmentation which is concentrating along the acrine openings, whereas here the pigmentation is larger and it is obliterate most of the acrine openings. The acrine ostia are obliterated. the structures we commonly come across in dermoscopy. The colors are important to show where the melanin or pigment lies in the layers of the skin. So as the lesion changes its color from brown to blue or black to blue, the pigmentation comes deeper from epidermis to the papillodermis to the reticular dermis. And other colors have their own significance. So orange color or a yellow orange is indicative of granulomas. Now more and more studies are being done about the use of dermoscopy in the assessment of multiple granulomatous disorders, or presence of yellow gives you an idea regarding xanthomas, lipid deposits in the skin, whereas purple or violet and red, frank red color shows the evidence of presence of blood in different forms. Where, so here is how the color changes in the superficial black as it goes down due to the Tyndall effect. The color changes from brown to gray to blue. This white color on dermoscopy has its own relevance. So when it is a superficial, as we saw in the scales earlier, it is a superficial white color due to the scale. Whereas there is a group of structures that we should be specified among, and those are called the shiny white structures, where, so you can see in the picture, other than the hypopigmentation, you can make out, I hope you can make out these shiny white structures, which by visualization, we can understand that it lies slightly deeper when compared to the surrounding hypopigmentation. So these are structures which can be seen only with polarized dermoscopy, and sometimes you need to rotate the dermoscope over the lesion because these are caused by stromal alteration and fibrosis. And it is actually the collagen which is bifringent within the fibrotic element which shows up. So these are, they were typically described in melanomas and atypical lesions, but this is a lesion of lichen sclerosis atrophicaus. And in such conditions as well, when there is fibrosis going on, you can see these shiny white structures. Other terminologies usually used to describe morphological entities are structureless areas, dots, globules, lines, or circles, which can be due to any of the pigmentation or follicular changes that we mentioned, but they form these morphologies. So when you don't know what to call a lesion, try to find out whether it fits, the morphology fits in any four of these, and most likely it does. So these are the structureless areas where you don't see anything other than a bland color, which could be any color. So this is a structureless white color area, whereas here you can make out these small tiny dots and larger aggregates, which are globules. And these are mostly, as we described earlier, periacrine and perifollicular in their location. And these are how lines are seen on dermoscopy. So angular lines itself, it was initially thought to be specific of melanomas, but these are, as we discussed, findings seen in general dermatology also. So when you're describing this lesion, you can use the terminology of hyperpigmented lines in the border of the lesion. And these are circles, white circles, which can be seen as well. Now coming to the last entity of specific clues. So if you see some specific findings, then you can be, it is diagnostic. As we see Lichen striae, Lichen planus, especially in the mucosal lesions, dermoscopy makes it very evident. So presence of Lichen striae is specific for Lichen planus. Presence of this double track appearance caused due to the double-edged skin in it, it is specific of porokeratosis. So most of this is what I generally use. It's a Dermlite DL4N with an iPhone 6, and most of the images shown in the presentations are taken this way. Coming to a few more basic terminologies that we should be aware of. A normal pigment network or a reticular network. So this is a normal finding that we see in our color, or the skin of color, that is gaining more and more importance now. So what happens is we have the retid ridges and dermal papilla, and top of that in the epidermis there are melanocytic distribution. So when a dermatoscope is kept on the skin, and it perceives only a thin layer of the pigment cells which are in the dermal papillae. So that doesn't come up on the surface much. So that is seen as the holes of the net, whereas on the sides of the retiridges, the dermoscope can visualize the basal layer pigmentation better, and that shows up as a net of brown color. So it is all dependent upon where the pigment lies. Where the pigmentation is clustered, that shows up is this 3D pigmentation in 2D formulation leads to a reticular network of pigmentation. And so this is how it is seen. You can see how the net-like pattern of pigmentation is created by the presence of melanin. So here it is thin over the suprapapillary plate. It shows up as a hole. Here the basal layers pigmentation is thicker, so the dermoscope can see it as a brown color. Whereas where there are more acrine openings as in of the face, you see a pseudo-reticular pattern. This is just for comparison on a video dermoscope. I think this was a dynolite that was used. So in 50x magnification, the picture changes a bit. And this is how it appears on a video dermoscope. Coming to a few clinical scenarios. So these presentations, a 50-year-old male, chronic skin lesions, multiple treatments taken, both modern medicine and Ayurvedic applications have been done. So predominantly there is itching, scaling, and patches and plaques. So when we are assessing it clinically and describing, these are the general terms we are using. But then through a dermoscope, we see the subsurface findings. So these irregular dotted vessels in this picture, along with the superficial white scales, are diagnostic of psoriasis. And even if you are not sure of the diagnosis with the one finding, and we want to go ahead with a skin biopsy, if you choose areas like this, you are in a better position to get a confirmatory diagnosis. So in psoriasis, when we do grattage before the bleeding spots appear, just the superficial scale when removed, you can see the auspit sign, and this was described as the dermoscopic auspit sign. You can see that these regular dotted vessel um, is due to the regularly elongated psoriasiform hyperplasia and the dermacapillary vessels. Whereas here you can see the color of the scale changes. It is more yellowish, which indicates a presence of serum and other exudate. The vessels, though dotted, they are patchy in distribution. They are not of the regular caliber as we saw in the other case. There is a difference in the activity of the lesion, and this is more indicative of an eczematous process. Whereas here, you can see the scaling. These are the vellus hairs, and these translucent vellus hairs with presence of scales which are more concentrated there, and presence of micropustules are indicative of tinea incognito. And because this is a epidemic we are facing now, steroid modified tinea, more and more findings are being described, and studies are being done for standardization so that we can diagnose with certainty in doubtful cases and rule out other close differential diagnosis. And Tinea Capitis also can be, though we are not covering trichoscopy here, just to for completion's sake, the presence of Tinea Capitis or involvement of tinea in the hair or the glabrous skin shows many specific findings, which include the comma hair or the Morse code hair, the barcode hair. So this is basically the fungal hyphal invasion leading to breakage of the shafts, and the zigzag hairs are formed. So presence of this hair, though it is mostly seen in Tinea Capitis, involvement of the hair of the glabrous skin due to tinea can clinch your diagnosis. And the ultraviolet dermoscopy has been now put to use for species identification also, and the latest published paper shows that the green fluorescence, which can be identified on UV dermoscopy, can be closely correlated with the tryptophan metabolites released by microsporum species, and some amount of species identification is also possible with the use of dermoscopy. Another common scenario that we face, the facial lesions, and where we are putting to use the terminology of inflammoscopy to use of dermoscopy to delineate structures of inflammatory disorders. So it all looks red and scaly on direct examination, whereas on dermoscopy, the picture is much more clear. So you can see these severely telangiectatic vessels which are distributed throughout the lesion, along with some amount of superficial atrophy and pigmentary changes. So this is classically described associated with topical steroid damaged skin changes, whereas here the vasculature, you can see that these are linear and branching vessels, but they are not interconnected. They form a reticular pattern or a net-like complete and incomplete net-like pattern is formed by these vessels, which are specifically associated with development of rosacea over the skin and presence of follicular plugs. You can see these are the follicular plugs which have been marked. So these white or gelatinous filaments are described as the Demodex tail. So either it could be the presence of the Demodex mite itself or associated serum and keratin, which is deposited within the follicular openings, and follicular dilated plugs with perifollicular halo denotes the presence of Demodex on the skin. So if you want to demonstrate and you identify an area like this on dermoscopy with your tape stripping method, your yield of Demodex will be better and you can come to an early diagnosis. Another scenario, a young male presenting with itching and red patches over the palm of a couple of months duration. So usually we start with a common differential diagnosis of Pompholyx or eczematous changes associated with allergic contact dermatitis. But dermoscopy showed something else. There were yellow plugs within the oval pits in the Palmar skin. So these plugs and were retained in some areas, whereas some of them were empty. And we took a biopsy because it looked something different, and we could confirm the diagnosis of a Palmar Lichen Nitidus. So the claw clutching claw clutching appearance of the infiltrate, and this infiltrate along with the exudate shows up as these keratotic plugs within the oval depression. And in contrast, a close differential diagnosis in Pompholyx, you just see these deep-seated vesicles or structureless areas. So this is how dermoscopy can help you come to a diagnosis. Another common question that we face in the OP is this vitiligo. So white patches are always a concern, especially in younger individuals or children where a biopsy might not always be practical or feasible. So this is how vitiligo appears on dermoscopy. This chalky white color or this white glow is typical of vitiligo. And it is not just the diagnosis of a vitiligo patch. You can see on clinical examination the lesion is here. But on dermoscopy, it is possible to identify the spreading extent of the lesion better. And if it is a single lesion, I always try to scope the surrounding areas and ask them if you are starting on topical application. I try to mark an area where always the hypopigmentation or the depigmentation activities seem to extend beyond the single white patch. And if you can actually advise a patient to start topical application to cover that area as well, which has improved the results in most cases. When it comes to other close differential diagnosis, so a young child coming with a vague hypopigmented patch, which the parents feel it has increased in size or becoming more evident on dermoscopy, you can see that it lacks that white glow or that chalky white color that you can still make out. So this is how a nevus depigmentosus appears. You can make out the faint reticular network here. So as we know in Nevus depigmentosus, the melanocytes are there. It does not just reach the surface. So it does manage to retain a faint pigment network in most areas, and the lesion tends to have these pseudopod extensions. But that pseudopod extension abruptly stops. It doesn't shows an active infiltrating nature like that of a spreading vitiligo. It has a definite boundary which ends with those pseudopod extension, and there will be perifollicular and this periacrine pigmentation. So the perifollicular and periacrine area always retains pigments in the Nevus Depigmentosus. So this was a child who had a patch like this and was being treated with tacrolimus ointment with a diagnosis of vitiligo. But then it didn't show the chalky white nature. I wasn't sure whether it is because of the treatment response. So I did the scraping and it made out the scales, the double-edged scales, which is restricted to the skin marking, and this is typical of pityriasis versicolor on dermoscopy. Coming to pityriasis alba or follicular eczema condition, where you can see some, so this is a zoomed view where you can see the brawny scales, which may have a follicular location, or it can be seen throughout the lesion, and faint vasculature, which is patchy in nature, indicative of the eczematous process going on there. Now, we'll briefly touch about the neoplastic lesions and dermoscopy. So dermoscopy, as we all know, it evolved as a tool for the diagnosis of melanoma or to early um, uh, identification of lesions which had the risk of melanoma in the Caucasian population. So dermoscopy has maximum work done in neoplastic lesions, and initially it was based on a pattern analysis. So a particular pattern will be looked for in the lesion, and based on that pattern, the lesions will be divided into benign, dysplastic, or malignant. But then when more and more studies became available, it was concluded that pattern analysis has its own pitfalls. So now dermoscopy neoplastic lesions is used based on these three parameters. So we employ pattern analysis, we look for lesion specific features, and of course the color and symmetry of the lesion. So this is a very simplified algorithm because too much of it is beyond the scope of this particular, we are in this limited time. So the first question in a neoplastic lesion is whether we are dealing with a melanocytic lesion or a non-melanocytic lesion. So majority of the melanocytic lesion will show the reticular pigment network. The pigment network may be altered. It may have its own changes. But if you can identify a pigment network within a lesion, most likely it is a melanocytic lesion. And once you have identified the melanocytic lesions, then the rest of the differential diagnosis follow. So we use pattern analysis, or we use the ABCD to the asymmetry border color. We add dermoscopy, and there is which is the Stolz method. Then there is Menzies method. There is use of 7-point checklist. So many algorithms have been put to use to differentiate a melanocytic lesion between its benign and malignant features. Whereas if there is no pigment network, then we have to think about the non-melanocytic tumors. So the non-melanocytic, these dermoscopic findings of these common ones have been well established. So what is pattern analysis? So it is the simultaneous assessment of the diagnostic value of all the features a particular lesion shows. So till now, what all terminologies were we using? It was all those for the general dermatology. Here, the most important element is the pigment network and what has happened to the pigment network. So it can be, there are lot of findings, and broadly, they are differentiated into the global pattern of the lesion and the local features, which depends upon where the lesion is located. And there are more simplified ones. The first or the straightforward one we can use is a 3-point checklist. So asymmetry, atypical network of or blue-white veil. So we saw that here the pigment network compared to the ones that we saw earlier. In one look itself, if we can make out this is atypical and the lesion is asymmetrical. And chaos and clues on dermoscopy, it shows that a lesion has more than one pattern. So the easiest way to look for chaos on dermoscopy is to cut through a lesion. Imagine that you're cutting a lesion in the center. And if the two sides are not mirroring themselves, then the lesion is chaotic. So the chaos could be because of the shape, it could be because of the structure, it could be because of the color. So if there are chaos, then that lesion is suspicious. And then you look for other clues. And coming to local features, so the most common one that we need to make out is the Palmar nevi and the palmoplantar nevi and other suspicious dysplastic or melanoma lesions. So local features, palms and soles have their own specific findings of parallel ridge pattern. So, so this is the sole, and you can see these thick ridge and the thin furrows. So it could be the concentration of the pigment could be in the ridges, which is called the Palmar ridge pattern, or it could be the parallel ridge pattern, or it could be in the furrow where the thick ridge is paired. This is the furrow pattern, or it can show lattice pattern. It can be a window-like connection between these different ridges or furrows. So this is an example of where each lesion have its own local feature depending upon where it is located. And when it is a melanoma, so acral melanoma is common in our population as well. So the broad ridge pattern, you can see that the pigmentation is mostly in the ridges over here. And along with that, the lesion is completely chaotic. There is no asymmetry in color, structure. There are irregular to brown clots, and there is irregular fibrillary pattern also. And these regressed areas or structureless areas. So the blue-white veil, which is included in the 3-point checklist, is an important finding in dysplastic lesions as well as malignancy. So basically, it just means that there is a aggregation of heavily pigmented cells or free pigment, which is covered with a compact layer of orthokeratosis. So we saw earlier how the color changes on dermoscopy as the pigment is going deep. In a neoplastic lesion, the pigment may not be deep. It is just a tumorous proliferation where the pigment-laden cells are covered by the skin layer. So the presence of blue-white veil is an important feature that we should train our eyes to look for and identify, because the association with this dysplastic or malignant lesions are quite high. Coming to lesion, so clinically there is a hyperpigmented plaque which on the face which is showing erosion, crusting, and scaling. This was actually they gave history of a nodular lesion which was done Kochi from elsewhere, and this is what the dermoscopy showed. So this is a polarized view. Just to revise what we saw earlier, this whenever you're going through images in journals or books, usually it is denoted the type of the dermoscope, the polarized view, and the magnification. And so this is the 10x magnification on polarized view, and this is how the lesion appears. So let us see how we will describe here, because it is we are considering a neoplastic lesion. The terminologies are different from the general ones we discussed earlier, and these findings, these are called maple leaf area. So this is one specific terminology which is universally accepted to be used, and this is how the correlation of maple leaf happens. There are globules which are structureless round areas which are larger than small dots. There is no specific size which is mentioned, but then you can see a globular collection. And there are blue-gray areas which show deeper pigmentation. there is diffuse pigmentation, which again shows in globules inside, and there is erosion for with crusting. So this is a fulfills the diagnostic algorithm of pigmented basal cell carcinoma. And what is the most important finding? Absence of pigment network. So though the entire lesion is brown to black, you cannot see a pigment network inside. So that it shows it is a non-melanocytic lesion with along with any of the findings that we saw. And this arborizing telangiectasia, so this was the image that I had shown earlier for. This was a nodular BCC seen in a patient with oculocutaneous albinism. So you can very well clearly see the vessels here. Otherwise, in pigmented skin or skin of color like our population, the vasculature might be a little bit difficult to appreciate. So how can we correlate them histologic? How does it happen? So the maple leaf areas are actually caused by multifocal tumor nests with pigment aggregates which are interconnected by these lobular extension. So when these lobular connections happen, especially in the advancing border of the lesion, it forms these maple leaf-like area. And the spoke wheel-like areas are also caused by the tumor nest, which contains pigmentation inside or pigment-laden cells, and which shows connection to the superficial layers and connection to the epidermis. Whereas when these pigment aggregates are deeper, it causes blue-gray ovoidness and erosions on the superficial surface with artifactual clefting causes these different pigment islands along with the scaling and erosions. So this is how histopathological correlation is evident for most of the dermoscopic findings now. And that is why in the earlier slides we described how dermoscopy is not a standalone examination tool. It's not just a standalone examination tool. It is a bridge between clinical and histopathological changes that happens in a lesion. Just for comparison, both these skin lesions, they have, when you are describing them, we see hyperpigmented plaques or variable pigmentation. There are papules over here, there are erosions, and clinically, though the description in this was my own patient. My differential diagnosis was pigmented BCC, but then dermoscopy, you can see how different it has showing up. So this lesion has all the features that we described earlier, along with the maple leaf areas. There are blue-gray ovoidness and erosions. Whereas coming to this lesion, you just look at the border. The border always give you a good idea about the type of the lesion that you are dealing with. A well-defined border where you can see these structures. These structures are the komodo-like openings, which are the specific feature of seborrheic keratosis. So these borders in comparison with the infiltrating border, it is much well-defined. There are komodo-like openings. And though there are blue-gray collection of pigments which can be ovoid in nature, they are much superficial and they don't form those spoke wheel-like areas or the connections as in maple leaf structures. And this papule, though it showed a hemorrhagic surface, the rest of the area didn't show the findings that we described in the BCC. So on histopathology, this was actually a case of clonal seborrheic keratosis, whereas this was, because this fulfilled the criteria for BCC, it was completely excised and the diagnosis was a nodular type of pigmented basal cell carcinoma. So this is how dermoscopy can differentiate to some extent between the skin lesions and aid you towards early diagnosis or decisions regarding sampling techniques or complete excision. So nowadays, with more and more literature that is available and more sophisticated instruments which are becoming more economical by the day. It is an easy to use and easy to learn tool. And yes, I agree there are gray areas, but then definitely the more you do, the more we see, and of course, with more mistakes, we learn more. Thank you.
Very beautifully presented, and we are all enriched by your talk. And of course, the postgraduates will really cherish this talk. And my advice to the postgraduates is that simply by hearing this, always you may think that you can very easily do dermoscope and interpret the findings, but that is not exactly correct. The guidance is given, and you have to practice more and more, and then you must become a very well-versed person to use dermoscope. So, buy a dermoscope and use dermoscope frequently, whatever be the lesion, whether it is pigmented or non-pigmented, or is it a plaque, or is it an inflammation, or even a vesicle, you can do the dermoscope, and you can be a good person to interpret the findings and make a very good clinical diagnosis with the help of dermoscope. So as Dr. Jayasree has put it very clearly, dermoscope is not standalone investigation or instrument. And the dermoscopy, the clinical diagnosis, history, clinical features, and dermoscopy, and then go to the histopathology. And finally, correlating everything, you can make a good diagnosis. I think that will be the message Dr. Jayasree has put across. Thank you, Dr. Jayasree, for your nice talk. Thank you.
Thank you.
Congratulations to all winners. We will meet next month. Thank you very much.
Thank you, sir. And
Thank you.
Eastwas Pharma saying thanks for our heartfelt thanks to Dr. Crichton, sir, to arrange such a wonderful program as a course director. And we extend our gratitude to Dr. Jayasree Puravoor as a speaker. She has given lucid her experience to benefit for our PGs, and our PGs got benefited from this session. So the same way Eastwas Pharma will continue every month as a course for all dermatology PGs for all India. My dear PGs, kindly share the details to your colleagues also for the forthcoming programs. They will also be benefited. And Eastwas Pharma is always committed for the academic sessions. Thank you, doctors. And anything questions is, I think no questions from chat box. Thank you, doctor. Thank you so much. Have a great day to all.
Thank you, sir.